I don't think Dr. Frye needs much introducing. This is Dr. Richard Frye. He's here from the University of Arizona, College of Medicine. He's going to be talking about childhood onset neurobehavioral syndromes, the overlap between immunological, metabolic, oh gosh, what is that? Epileptiform etiologies. Welcome, Dr. Frye.
Thank you so much. So thanks a lot for inviting me to come and talk. Yeah, so this talk is kind of put together to be more of an overview than the nuts and bolts of things. And you know, when we try and figure out all these entities, why kids may have certain types of disorders, and try and name them. You know, I've tried to go through and try and figure out, well, do we have a certain way of diagnosing them? Do the names that we use, because many times they're very confusing, how do we use them? Are we using them properly? What are the things that we can really look at, that we have to look at to really look at the child as a whole? So I'll just go through my disclaimer. So many of the treatments, if I talk about treatments, many of the treatments are not FDA-approved treatments. They're used off-label, so it's important to have a practitioner that's very familiar with any types of treatments, or don't do this at home. So, well, on your own, at least. There's many, really many different names for many of these disorders, and first I'd like to talk about sorting out all these different names that we have for acute onset of neurologic, developmental, and behavioral symptoms during childhood. And so if you look at the different acronyms that have come up, we have these things, there's something called PANDAS, pediatric autoimmune neuropsychiatric disorder associated with strep. We have PANS, and a lot of people use these interchangeably. But then also there's other types of criteria for diagnosis. There's the PITANS, and then there's also the CANS, and there's probably other ones that I'm leaving out too. And so I think it's important to kind of see, what are the diagnostic criteria, where they overlap, and what things are left out, and what questions there are to ask. So one of the first entities was really, PANDAS, pediatric autoimmune neuropsychiatric disorders associated with strep, really implicating strep as an infectious agent. And so how do we really diagnose this? What is the criteria? So one of the things that the child has to have, so it's prepubescent onset, so it's in childhood. There's presence of obsessive compulsive disorder type symptoms and/or tic disorder. So it can be either one. In this diagnosis, there's an episodic course with waxing and waning. Neurologic abnormalities also have to be present. Things like choreiform movements, even if they're subtle movement disorder. And we have to look at some type of temporal relationship with group A strep infections. And this is really one of these first entities that was introduced. And there's been a nice study, of course, by Sue Sweeto, who was really the one that described this entity at the NIH. And she did a study where she compared different characteristics of individuals with PANDAS in 3 different centers to see how they compared. One of the things in this study that was very interesting, this first table just shows some of the basic characteristics, but really I think what this paper started to open up, that it's not just tics in our obsessive compulsive disorder, but there's all these other symptoms associated with it: anxiety, emotional ability, irritability, developmental regression, deterioration in school performance, somatic signs, and others. And if you look at some of the more detailed symptomatology that was really reported in high incidence, so there's things like separation anxiety that is new onset. Of course, OCD type symptoms of aggressiveness, hyperactivity, hallucinations, dysgraphia, not being able to write very well. Interestingly, I think one of the ones that always interests me so much, and it was a light bulb that came up in my head because I always kind of dismissed the symptoms, was acute onset of urinary urgency. So these are kids that suddenly they have to go to the bathroom every 5 minutes in the class. And many times they'll come in and they have been referred to a urologist because they think, well, they must have some type of urinary tract infection. And actually it's part of the syndrome, this kind of compulsive feeling of needing to empty the bladder. So it shows, and sleep problem and restricted food intake. And so these are other symptoms kind of expanding the symptomatology of what we consider PANDAS. Then we have PANS. So let's see, let's take a look at PANS and see how it differs. So PANS is an acute dramatic onset of OCD or severe restriction in food intake. So right here we see that there's some differences in PANS and PANDAS. PANDAS, you can have a waxing and waning. You're supposed to have a waxing and waning recurrent symptoms, whereas PANS is defined as you can have one-time thing. Also, you need to have OCD type symptoms. So if you just have tics, you really can't be diagnosed with PANS if you don't have OCD symptoms also. In addition, you need to have at least 2 neuropsychiatric symptoms, either anxiety, emotional lability, irritability, behavioral regression, deterioration, or other types of symptoms. So we see here there's a little bit disconnect between PANS and PANDAS and the way it's described. This is a nice study on PANS, which by Tanya Murphy, who introduced a number of things in this paper. One showing that there could be many different infectious type of triggers besides group A strep. And then this is a nice paper because it started to actually pull apart these symptoms and show with this what they call a cluster analysis, that there's 2 different types of clusters of behaviors. The top cluster of behavior, kids that had ADHD symptoms, and tics and group A strep infection and sleep, and the bottom, others with food restriction, fatigue, gastrointestinal symptoms, possibly mycoplasma, and maybe more psychiatric symptoms. Then we have this thing called PITANS, pediatric infection triggered autoimmune neuropsychiatric disorder. Again, has to be of pediatric age. And now in PITANS, you can have OCD symptoms or you can have tics. So tics are brought back into it. This does include having these exacerbations, this waxing and waning, and also having certain types of movement disorders. We can see in E that the child displays some type of neurologic abnormalities. And this is defined as having some type of infectious trigger. Whereas if we look back on PANS, PANS really does not actually say that it needs to be an infectious trigger. It actually doesn't say that what the trigger has to be, what type of trigger it has to be at all. And so this differs suddenly. And then we have CAM, the childhood onset neuropsychiatric syndromes type of diagnosis, which is a little bit more broader. Again, this includes a wider range of childhood. So the others actually only really apply to prepubescent children. This goes throughout childhood. This is another disorder, has to have acute onset. Here, they've actually expanded the definition so it could be an infectious trigger or an inflammatory disorder. So it could be, it seems to be involved in the immune system as the trigger, but it doesn't have to be an infectious trigger. There needs to be, now here, whereas in the other criteria, they talk about OCD specifically as a psychiatric symptom and tics as a motor symptom. Here they've expanded. They said there has to be some type of psychiatric signs, which could include OCD or anxiety or psychosis. And you have to have some type of motor sign, some type of abnormality of the motor movement. But this could be tics, dysgraphia, clumsiness, hyperactivity, so making it more general. And this could be a monophasic or polyphasic type of disorder. So that could be a one-time thing, or it could be something that's recurring and relapsing. So, so we have all these kind of definitions. They're both based on symptoms. They're not really based on biology. So I want to talk a little bit about, I think, some of the work that has really started to nail down what the biology of some of these disorders are. And I think we can turn to the work by Madeline Cunningham. And she did something that was really smart. She studied individuals with Sydenham's chorea, which is a movement disorder that's induced by a strep infection. And these, although we talk about the chorea, which is the movement disorder, really these patients also have a lot of psychiatric symptoms, OCD symptoms also. So they overlap very much with the PANDAS population, although it seems to be much more severe. But here we know that strep is the trigger. And so she did a number of things. First, she asked, well, what is the exact trigger? You know, many times in PANDAS, we look for just strep antibodies. She asked, what is the exact strep antibody? What is the exact target of the strep? And she identified this lysogangliosomal GM1 entity where the strep actually attacks. But the thing that she did, what was really important, is she found out what happens when that antibody attacks the cell. What does it do to the cell? And what she identified is that when the antibody binds to the cell, binds to the neuron, it increases the activity of an enzyme in the cell called Cam Kinase 2. So we can actually know what's going on inside the cell and why these things are happening. And the importance of Cam Kinase 2 is that it regulates some really key neurological pathways. One of them is an enzyme called tyrosine hydrolase, which produces dopamine. So when Cam Kinase 2 is elevated, then you start to make more dopamine. And dopamine, too much dopamine, can cause movement disorders. It can cause obsessiveness, it can cause aggression, it can cause a lot of different symptoms. The other thing that the Cam Kinase 2 does is it activates and regulates two major neurotransmitters, neurotransmitter receptors, the NMDA receptor and the AMPA receptor. And both of these receptors are important in learning and glutamate metabolism. So you would say, well, why would that be, how would that relate to neuropsychiatric symptoms? Well, one of the ways that we learn is these receptors cause something called long-term potentiation. That is, if we learn something, it reinforces certain pathways in the neuron that we want to remember. But we can't remember things forever. You also have to have a system that helps you forget about something so you can move on to the next thing. If you were always learning the same thing, what would happen? You would obsess over it. You would have compulsions. And so what we see here is an imbalance in this system that's important for learning, where you have too much long-term potentiation, or we're reinforcing only one thing over and over and over again, and giving these type of compulsive type of symptoms. She also showed that these antibodies bind to the basal ganglia, which is a very important part of the brain, where control for movement. And then she also showed that this Cam kinase that's elevated in the cell was very elevated in individuals with Sydenham's chorea, and you can see that with the red dots over on the left side. And that if people without PANDAS or any symptoms don't have any elevation in Cam kinase. You can see the green dots on the left-hand side of the graph, and that those with PANDAS, those blue dots in the middle, seem to be right in the middle of there. That is, that their Cam kinase is elevated, not so much that they have Sydenham's chorea, which is very severe, but to the point that it's abnormal. And then she also, if you look over the right graph here, compared the kids with PANDAS phenotype to those with OCD, tics, ADHD didn't have that PANDAS phenotype, and showed that Cam kinase was elevated for those with PANDAS. So really getting down to what the molecular mechanisms are inside the cell. Other studies that really that reinforce the idea that strep may be involved. This is a nice study done by Cunningham and colleagues, where they actually looked at kids with symptoms that were positive and negative for strep. And so what they saw, and you can see in the upper left-hand side, is that kiddos with both OCD and tics were more likely to be positive for strep. What she also showed, you can see this down in the bottom left-hand graph, that the Cam Kinase, again, was elevated in those with OCD and tics compared to controls. And the upper right-hand graph, you can see that the individuals that had tics and OCD had higher Cam Kinases than the ones with tics and or OCD alone. So Dr. Cunningham has told us a little bit about these entities, but there's still a lot of unresolved questions when we even talk about these disorders that we use to diagnose, and there's some discrepancies. You know, first of all, are we talking about infectious triggers? Is it an inflammatory trigger without some type of infection? Can it be both? If it's an infectious trigger, is it a chronic infection? Is it an acute infection? It's very important for treatment. If it's just a trigger and there's no chronic infection, there's no reason to be treating any type of chronic infection. Are these symptoms specific to OCD and tics? It seems like those are what some of the original criteria have really concentrated on, but we see there's a broader range of symptoms that are really included. Is this just a one-time disorder, or do we have a waxing and waning in different kids, or is it on a continuum? And what are the pathophysiological mechanisms? You know, is this just immunological abnormalities, or are there other things too? And so this is a diagram Dr. Sweeto put together to kind of make a hierarchy. Although I would argue that this really doesn't capture this hierarchy very well, because we can see PANDAS is down lower in the hierarchy underneath PITANS, which is underneath PANS, but PANS, but PANDAS can't be underneath PANS because it includes tics and/or OCD. So there's a lot of thought that we need to do and to kind of reorganize our thoughts of how these things are really organized. The other thing is that although the immune system is important, there's really many other pieces that we have to think about. And that's when we look down here to environmental factors and metabolic factors, which we'll talk about now. Because of the fact that other types of acute forms of behavioral regression happen for other entities besides these immune system abnormalities. Although the immune system, you'll see, may be very intimately involved. We have developmental regression with certain types of epilepsies, which we'll talk about, in autoimmune encephalitis. We have cerebral folate deficiency, and we have mitochondrial disorders where we see neurodevelopmental regression, which is all important to think about when you're treating the patient and trying to diagnose the patient, because it's not just one entity. So what about developmental regression with epilepsy? What is the evidence for this? So I'll give you one of our studies that we did, a survey study I did with Dr. Adams. We asked patients of kiddos with autism and seizures to tell us about the child's development. And what we found is about 28% of those with clinical seizures say that their child regressed into autism. And when we asked what was the trigger, 40% of the time it was a seizure. We call this autistic epileptiform regression. So there's a form of regressive type autism which starts out with seizures. There's other types of disorders such as Lambert-Kleffner syndrome. And this is a disorder where after 3 years of age, children will regress and lose language specifically. They don't have autism symptoms, they just lose language. And many of them don't have any clinical seizures at all. But if you put an EEG on, what you actually find out is that there's these discharges, epileptiform discharges in their temporal lobe, the part of the brain that's important for language, that is very frequent, and it's interrupting the way that the brain works. Interestingly, This disorder doesn't respond all that well to anti-epileptic medications, but responds to immunotherapy such as steroids and IVIG. There's another seizure disorder called status epilepticus during slow wave sleep. And this is a very interesting disorder. Children will regress and have autistic symptoms. They many times don't have clinical seizures during the day. But if you put an EEG and look at their slow wave sleep, a specific part of sleep, you'll find out that 80% or more of their sleep is filled with generalized epileptiform discharges. And so they'll have actually seizures during sleep. And the only way you can find that out is by doing an overnight EEG. Again, this is another entity that doesn't respond all that well to anti-epileptic medications, but responds to immunotherapy such as steroids or IVIG. And then we have the subclinical epileptiform discharges, which are similar to what we see in Landler-Kleffner syndrome in children with autism, but they're wider spread. They're not just in the temporal lobes of the brain, but they're in the frontal lobes of the brain. The frontal lobes are very important for controlling behavior, for learning, for socialization. And some people, it's controversial whether these are really meaningful or not, but there's studies such as this one that have looked at these epileptiform discharges in psychiatric patients and found that if you treat them, you can actually improve psychiatric symptoms. And this is just a case, many of the studies listed out where they've actually shown this to be the case, including one study that we had of 21 children where we showed that they improved significantly in their development if these are treated. Then we have what we call limbic encephalitis. And this is when antibodies attack the brain and cause seizures. And there's many different types of antibodies. The one that's talked about many times now is one to something called the NMDA receptor. But we also know that there's antibodies to the voltage-gated potassium channel, the AMPA receptor, and the GABA receptors. This causes acute onset seizures, many times refractory to drug treatments. Another entity that has been described in the past is fever-induced refractory epileptiform encephalopathy, which is very hard to treat with drugs, has been linked to the elevation in an antibody to the voltage-gated potassium channel. And so there's some nice studies that have asked, how do you treat these entities? And in this study, they showed that that improvement was much more likely if you used immunotherapy rather than not using immunotherapy, showing that some of these seizures are really due to antibodies in an autoimmune process. Then we can look at autoimmune encephalopathy, and this is just a case I'll point out, which we published of a 3-year-old with childhood disintegrative disorder, which is the first case of the N-type calcium channel antibody causing autistic regression after 3.5 years of age. And in this case, we were able to treat with IVIG, and you can see from the graph that with treatment of IVIG, there was a decrease in the titer and the child improved. So one of the really places where we seem to be able to make a lot of headway in treatment is with discovery of the folate receptor alpha autoantibody. And this is a really interesting entity because this is an example of how an autoimmune disorder can cause a central metabolic disorder. And it shows the overlap between metabolism and immunity. So cerebral folate deficiency, which the folate receptor antibody causes, was described in about 2005 by Rainmakers and other colleagues. And they had noticed that there were these children that had regression, neurodevelopmental regression, and then neurologic symptoms, and then seizures, starting at a little bit before a year of age. When they did a lumbar puncture and looked at the cerebral spinal fluid that surrounded the brain, they found that the folate level was very low. The first thing they did is they looked at the folate transporter and they looked for genetic abnormalities in that folate transporter. That's what they thought it was. And they didn't find any at all. So Dr. Rainmakers engaged Dr. Quatros at SUNY Downstate. And what they found is that there are these antibodies that actually interfered with the way that folate was transported into the brain. So the major way that folate is transported into the brain is something through the folate receptor alpha. And you can see that on the bottom there, the FR alpha. So folate binds to those receptors and then is transported across the cell up into the brain. That requires energy, so kiddos with metabolic disorders and mitochondrial disorders also have problems doing that transport since it takes energy. But you also have these two antibodies, one called the blocking antibody, which you can see in purple, and that binds onto the folate receptor alpha and does not allow folate to bind onto the receptor, so it blocks it. It's called the blocking antibody. And then there's the binding antibody, which is in yellow, which binds onto the folate receptor and just kind of messes with its ability to work. So luckily our body is set up with an alternative carrier called the reduced folate carrier, which is in the middle there in orange between the two folate receptor alphas. And you can see it's much smaller, and it's much smaller because it doesn't have the same affinity for folate. So it doesn't like folate as much as the folate receptor alphas. So to really use it, you have to have higher levels of folate in your blood. And it will only transport reduced folates. So folic acid, which is very common and we supplement our food with, is the oxidized form of folate, and it's not immediately bioavailable. You need a reduced type of folate to go through this carrier. So when some of these cases were reported, they found the folate autoantibody, they also mentioned that many of the children had symptoms of autism. They didn't make a big deal of it in the first paper. But then in about 2010, myself and my colleague Dr. Rossignol asked, well, if they have all these cases of these kids that seem to have autistic symptoms and have these antibodies, how many of the kids that we're seeing in our clinic may actually have these antibodies? And so we offered this test to patients that came into our clinic. And what we found is that 60% of the children were positive for the blocking antibody, either low, medium, or high. And that 50% of the children were positive for the binding antibody, low and medium. Overall, 75% of the children that we tested were positive for one of the two antibodies. So from the earlier studies, we knew that the treatment for this is a reduced folate called leucovorin calcium or folinic acid. And we thought that it was reasonable to give a trial of leucovorin if the children had this antibody. And so what we did is, in 44 of the patients that were positive for the antibodies, we treated with leucovorin. And 4 months later, we asked the parents to come back, approximately 4 months, and tell us whether certain symptoms got better or worse. And we compared this to something called a waitlist control group. That is a group of kiddos that, for the most part, were waiting to get results for the folate autoantibody, but hadn't made any changes to their intervention. And what we found is there was a statistically significant effect in improvements in receptive and expressive language, and verbal communication, stereotype behavior, and attention with treatment with leucovorin. Since then, and last year, we published the double-blind placebo-controlled study where we showed that leucovorin improves language in children with autism and that the folate autoantibody is predictive of those that will respond to the treatment. So one of the other pieces that's very important also is mitochondria. And we see mitochondrial disease and mitochondrial dysfunction very commonly in all types of neurobehavior, neuropsychiatric, and developmental diseases. And the mitochondria is very much intimately related to the immune system. The mitochondria, if you don't know, is a part of the cell that mostly is responsible for producing the energy, so it's like the battery of the cell. Depending on how much energy your cell needs, you may have anywhere from hundreds to tens of thousands of mitochondria in your cell. The mitochondria is very special. It has its own genome. So there's a limited number of genes that actually are coded by the genes within the mitochondria, although most of the genes that control the mitochondria are in the nucleus of the cell. So it's very complex. The mitochondria is also at the center of all metabolism in our cells, so it's very important. One of the things we know is that children with autism and mitochondrial disease, and this is from a review paper where we looked at all of the studies that have reported kids with autism and mitochondrial disease in the literature, and we went to see if there was any type of special characteristics they had as compared to run-of-the-mill or general children with autism. And here we found that those children with mitochondrial disease and autism were more likely to have developmental regression and seizures. What's really interesting is the paper by Schaffner, where he is a specialist in mitochondrial disease, and he asked the kids that he diagnosed with mitochondrial disease that had autism, how did they get that autism? And what he found is 60% of them regressed into having the autism. They had normal development until a point, and 60% of them regressed into having autism, and probably had underlying mitochondrial disease before time. What's really interesting is that 70% of those that regress into having autism, it was preceded by a fever of 101 or greater within a week or two. So there was some type of clear inflammatory trigger that actually triggered them and to develop those autism symptoms. Another really important study that shows the links between mitochondrial disease and mitochondrial dysfunction and the immune system is this study that looked at kiddos with mitochondrial disease. And kids with mitochondrial disease can have these neurodevelopmental regressions. And they asked, when do these neurodevelopmental regressions occur? They found that 72% of the time when a child with mitochondrial disease has a regression, it's associated with some type of infection. And what's really interesting is they were able to actually look at the timing of this. So we can see on the bottom right-hand graph that the infection, the symptoms of the infection happened over the first week with a peak at about day 4, but the neurodegenerative event, the neuroregressive event, didn't happen until over a week later. So there was a delay in this effect of the infection on the child's development. We know that there's other connections. This is a case where we found a child that had mitochondrial dysfunction, and we treated him for the mitochondrial dysfunction, and his behavioral symptoms improved dramatically with treatment for the mitochondrial dysfunction. But then he actually had a PANS, what we consider a PANS or an acute onset of neurobehavioral regression with worsening of symptoms considerably. He was found to have an autoimmune encephalopathy. He was treated with IVIG, and with the IVIG, there was improvement in both his behavioral symptoms and now his social symptoms, something that wasn't improved before, but his socialization improved dramatically. We also know from this case, it's an interesting case, that when we looked at markers of mitochondrial function before and after the IVIG infusions, that those markers actually worsened. So lactate, pyruvate, alanine, and alanine to lysine ratio got worse with IVIG treatment, telling us that that treatment, IVIG, actually puts a strain on the mitochondria. And it's very important because we've had cases of kids that got IVIG and they didn't do well, and the reason they didn't do well was because they had an underlying metabolic defect, problem with mitochondria, that wasn't actually treated before time. We're learning that the mitochondria, which is kind of in the center here of this cartoon, is associated with many different aspects of the immune system. It's important for metabolism in T cells, which we see on the bottom. T cells are very important for regulating the immune system. It's important for macrophages, which hunt down and destroy bacteria. It's very important for initiating something called the inflammasome, which is the initiating step that causes inflammation. So abnormalities in mitochondrial function have direct effects on the immune system. We've actually made more connections in some of our research with Dr. Janucci, who looks at children with autism and measures cytokine profiles. We actually found that the cytokine profiles, which indicate inflammation in the children with autism, was correlated with mitochondrial function. So we know that the two are very, very closely related, inflammation and how well the mitochondria can function. One other important aspect of everything is really redox metabolism and oxidative stress, because it's very closely connected with the mitochondria and immune disorders. We know that the mitochondria itself is a major producer of something called reactive oxygen species, which can be toxic to the cell. So it has its own antioxidant system within the mitochondria. And so this is very important for it to function. The redox system and the production of glutathione is very important. So the other thing that we know is that when we produce reactive oxygen species, it can cause damage to the cells, damage to the mitochondrial DNA, and actually induce inflammation and cytokine production. So it's an important component. So really, I think we have to look towards what we call an integrated model of all these physiological abnormalities to understand how they go together. We can't just treat one thing. We have to treat many of these entities. And this is just a model that tries to put it together. If you have an infection not only causes inflammation and production of antibodies, but can also cause mitochondrial dysfunction. Both inflammation and the mitochondria produce reactive oxygen species and cause oxidative stress, which then causes more inflammation and causes more mitochondrial dysfunction. One of the important things is to understand how these individual pathways actually cause symptoms. And then we can try and understand how to actually tailor treatments to the specific child and understand what the underlying biological abnormalities are. So with that, I thank you for your attention.
We're going to be opening up to questions.